and good afternoon, everyone. Welcome to the Mobile Health Program webinar series, Summer 2020. We are here for another Wednesday webinar, and we're so glad that you have joined us today on this beautiful sunny July afternoon. I am Noelle Duckworth with the University of Delaware's Partnership for Healthy Communities. We are part of the broader community engagement initiative across all colleges at UD. We are directed by Rita Landgraf, who gets to join us today and will be speaking momentarily. Our Associate Director is Erin Knight. I am the coordinator for the partnership. Paulette Hussey-Caston does our administrative support. Christine Sawinski is our mental health coordinator. And Kate DuPont-Phillips works with our Healthy Communities Delaware initiative. So thank you for joining us today. And being part. If this is your first webinar, we're excited to see you. If you've come back for some more, thank you so much for joining us again. We have a great crowd again today. We have about half of our participants identify as UD students. So thank you for your interest in this really important topic. We're going to learn more about how critical this issue is to our health and well-being, how to help people that we know and care about. And also how COVID-19 can, is impacting resources and safety and things for people experiencing domestic or sexual violence. We have about 11% UD faculty and staff, and then about half of our participants are also community members or are representatives of our community organizations and partners. So thank you again for joining us. I will turn it over now to, in a few minutes, to Christine Sawinski, who's going to talk more about the other webinars we have in store. We're almost done. We have one more next week for our summer series, so stay tuned. In terms of some quick technical details, we do use Zoom webinar for this webinar. Our audience lines are muted and will remain so throughout, and we won't be able to see each other on our participants on our videos or webcams. But we do encourage you to remain engaged. We'll be having some polls. We'll be asking questions to answer or discuss in the chat box, which many of you might be familiar when you do Zoom meetings. And if you have a particular question, a specific question that you'd like to ask our presenters today, there is a Q&A box. If you look at your Zoom toolbar, it looks like a little filing folder there. And you can go into the Q&A, type in your question. You can type it at any time throughout the webinar. And then during the discussion period, we will pose those questions to our panelists as time allows. So to keep your thinking cap on throughout the presentation. I know you'll have a lot of good questions to ask, and these are our community experts on this topic. So they are here to answer your questions. Today's webinar also is being recorded. And we will have that link up on our website at the end of the series that folks can access. And we'll also be following up with an email for anyone who attended with an evaluation link that we'd like you to complete. Again, if it's your first webinar, there's several questions to ask, so a few questions to answer. If you're a repeat customer, then please join again and just answer a few questions about this specific webinar and the presentation. It's very helpful as we hear from all of you about whether or not this series has been useful and what your thoughts are moving forward. Okay, Christine, can you take it away and tell us what else we have coming up?
Thank you again for joining us today for our 5th webinar in our Summer 2020 series. As Noelle stated, I'm Christine Sawinski, the project coordinator for the Mobile Health Program, and I'm very pleased to be part of a collaboration to bring mobile health services to Delaware communities while building workforce development for University of Delaware graduate and undergraduate students. Next week is the last week of our summer webinar series, and that topic is on nutrition and aging, and we do hope that you will be able to join us next week as well. And again, we thank you for joining us today, and we thank our presenters for being here. For now, it is my great pleasure to introduce you to Rita Landgraf, Director of our UD Partnership for Healthy Communities, Professor of Practice and Distinguished Health and Social Services Administrator in Residence, Managerial Operations Partner for Healthy Communities of Delaware, which is a collaboration among the UD Partnership for Healthy Communities, the Delaware Division of Public Health, and the Delaware Community Foundation. Once again, thank you to you all for being here today, and I will turn this now over to Rita.
Thank you, Christine. We are so happy that you've joined us, and hopefully that you may have been able to participate in our entire webinar series. We are very encouraged by the level of community participation, by the university participation, and by the fabulous speakers that we brought to you. I just wanted to give you a little background on our mobile health program. Everything that occurs at the Partnership for Healthy Communities is in collaboration with others. And our mobile health program is the same. It's a collaboration between our Lieutenant Governor, Bethany Hall Long, who is also faculty in our School of Nursing at the College of Health Sciences. Another vital partner in this partnership is St. Francis, as well as Highmark Blue Cross Blue Shield, and of course us, the University of Delaware Partnership for Healthy Communities. Now, our mobile health program is actually funded through a grant from Highmark Blue Cross Blue Shield of Delaware, and we're very grateful that they are also supporting our ability to go remote through this webinar series. The van actually was established to be able to bring UD faculty, UD staff, and UD students to the ground, primarily in communities within our city of Wilmington, where we know the health outcomes are not that positive based on health inequities, largely due to structural racism. And we're hearing a lot about that, not only because of COVID-19 and the inequity of the impact of COVID-19 on our brown and Black communities, but also because of the unrest and the social injustice that we saw relative to the magnitude of deaths that are occurring due largely to policies in our policing. But we know that that extends quite broader. And indeed, the van provides us an opportunity at the university to engage in these communities. And we've had such fabulous partners from the community at large that have opened up their doors and welcomed us in to give our university this level of engagement. And again, we are so thankful for that. Our first cohorts that went out on the van started in February of 2020. And if you remember, shortly thereafter, we were hit by COVID-19, and our governor, and rightly so, asked us all to shelter in place. So we were looking at, indeed, our van was disrupted, and also our community partners were deeply impacted by this COVID-19 disruption that to today, still is impacting us in a variety of ways. So on March 24th, we had the honor of partnering with the state of Delaware and created the COVID-19 Homeless Community Outreach Partnership. And that partnership, even though we couldn't utilize the van itself, we utilized the team from the van in concert with St. Francis to go out and really be able to support our homeless community, to first better able understand the impact of COVID on that vulnerable community, and then to bring forth some sheltering in hotels to protect that community from viral exposure, and if indeed they were impacted by virus, to provide them a safe place where they could shelter and still be able to receive their medications as well as being fed. We've learned a lot through that activation. Also, we were able to look for more permanent solutions to those individuals who were under our care, who were homeless, and many of those individuals have now gone on to a higher level of care, especially if they were challenged by mental illness and or addiction. What we were able to do as well was looked at creating initiatives that would enable our UD students to continue to engage with our community partners virtually. And that is to some extent what you are seeing today. Our current summer initiatives have been implemented in partnership also with the UD English department and the Behavioral Health and Nutrition department. at UD. We have partnered with internal colleagues at UD to create virtual health science field trips for one of our community partners during their virtual summer camp. And we have created, which you are participating in, this 6-week series of health and education outreach topics for not only our community members, but also in partnership with any other people who would like to join, including our UD family. We are very grateful for this opportunity. I am now very honored to introduce today's presenters. And these presentations will be focused on domestic violence as well as sexual violence, and recognizing and also what are the resources and how to refer when you recognize that someone needs this level of support. We are very concerned about individuals at this time because of COVID-19, and for many are not able to actually shelter in place safely because of the impact of domestic violence. And I know our experts are going to talk about that as well. The timing of this presentation is very much needed because of this level of impact for this vulnerable population. Joining us today, we have Courtney Winkler, who is the Training and Outreach Coordinator with the Delaware Coalition Against Domestic Violence. And along with Courtney, we have Megan Bettinger with the YWCA, and she's the Medical Community Engagement Liaison and the Medical Legal Partnership Coordinator for the YWCA, Delaware Sexual Assault Response Center. We're also very proud of Megan because she is a recent graduate from the University of Delaware's Domestic Violence Prevention and Services concentration. We're also proud of Courtney, but we wanted to highlight Megan's relationship with the university. So without further ado, I turn you over to our experts, both Courtney and Megan.
Great, thanks so much, Rita. That was a great introduction for us, and thank you for being proud of both of us. So my name is Courtney Winkler, and I'm joined by my colleague Megan Bettinger, and we are here to really just give some information and resources for those who are affected by domestic and sexual violence here in our community. If we could go to the next slide. Thanks. So the Delaware Coalition, we are Delaware's federally recognized state domestic violence coalition. So what does that mean? We are not a direct service organization, but we are here for resources, training, and support. So we are an organization who supports the organizations who are running the hotlines and the shelters. We are here to provide resource and best practices and making those community connections. We bring people together. On the screen, you see a few of our initiatives that we work on. A big one, like I said, is about training and resource assistance, but we also have a big hand in policy and system advocacy, whether it's policy at an organizational level or up to state or federal policies. And one of our biggest projects right now is really looking at violence as a health issue. We know that, and we'll talk a little bit more about this, but we know that, you know, folks who are experiencing violence and trauma, whether it's domestic violence or sexual violence or whatever it may be, we know that there are both short-term and long-term effects on folks' physical health, emotional health, and well-being. So we really know that that's an area that we need to focus a lot on. We also do a lot of work in prevention, trying to stop violence before it occurs. We know that that's probably not something we're going to see in our lifetime, but we're making baby steps toward and those strides to making a difference and creating safe and supportive environments. And finally, looking at issues of economic justice. You know, we know that creating economic opportunities is going to help empower people to be free and to make decisions on their own and to live a more healthy and well-rounded life. So we know that all of these things go together to create safe and supportive communities. And I'll let Megan tell you a little bit about SARC.
Thank you, Courtney. If we can flip to the next slide, thank you. And thank you, Rita, for that introduction. I apologize. I think I have the longest job title and one of the hardest last names, probably, of most of your presenters. But I am the medical liaison for the Sexual Assault Response Center. We're programmed through the YWCA Delaware. We're actually right across the street from the Big Bob, so we're pretty close to home for you guys at Star Campus. And we are a 24/7 domestic and sexual violence resource center. So we provide everything from a 24/7 hotline to counseling, case management, hospital confidence. But I'll talk about our services more in depth at the very end when we get into how to refer to us. But we are also one of those member agencies of the Delaware Coalition Against Domestic Violence that are one of those direct service providers. So we're in the community, we're working with survivors, and really our goal today and my role here is to help translate some of our best practices, like Courtney mentioned, what they do some training on, and then what we're implementing in the community is to try to translate as much of that to you all today and practice some of these skills. So I'll turn it back to Courtney.
So just some of our goals here today. Megan and I both are big fans of cat memes, so this may not be the only one that you see during this presentation. But together we will just look at some definitions and prevalence data, just recognizing how much of a problem that domestic violence or sexual violence is in our community. We'll look at the connection between violence and health, talk about how to respond, even if we are not somebody whose job it is to be responding, if we're not a domestic violence advocate or a hotline worker or a medical community engagement liaison, we are still receiving disclosures. People talk to us. So we'll look at how we can respond to folks who may be experiencing that violence. And then in turn, find some resources that you can direct people to, for yourself or for others, personally or professionally. So just starting off looking at the definitions and dynamics, if we could go ahead and look at, what kind of operational definition are we looking at? So domestic violence can be a lot of different things, whether you're talking legally, if you go to court, domestic violence is determined by family relations. So it could be a very broad net that we're casting there. But the things that we're talking about today are more closely related to what we would call intimate partner violence. So looking at relationship violence itself. And so how we would define that is really looking at a pattern of behaviors used by one partner over another to maintain power and control over their partner in a relationship. And so the pattern is something that's really important because we recognize that, we all have bad days. There's situational violence. There's violence that's related to lots of different issues that somebody could be experiencing. But in this case, when we're talking about intimate partner or domestic violence, we have somebody who is choosing to hurt and harm their partner and it can be in very different ways. But we also recognize that it's an ongoing pattern that may include violence, it may not. But if we go on to our next slide, we can get a little bit more of a sense about some of the things that are involved. We know that power and control is really the root of all of this intimate partner violence that we talk about. And it's more than just harming somebody through physical or sexual abuse. Those are the things that are readily seen and oftentimes people think about those things as the first things that come to mind when we're talking about domestic violence or sexual violence. And so over the years, there have been lots of studies, lots of research, talking to victims, talking to offenders about the different things that have gone on in abusive relationships and the behaviors that people have engaged in. And so through that research and through those findings, they've found and put together this illustration that you see on the screen called the power and control wheel. There are dozens of versions of this wheel to accommodate a multitude of populations and groups in specific circumstances. But really, the wheel depicts how violence or the threat of violence is a tactic that surrounds all the others. So the spokes of the wheel that you see, where you see, coercion and threats or intimidation or emotional abuse, those are all tactics that somebody is using to gain power and control over their partner. The physical and sexual violence, whether it's the actual incidents or the threat of that violence, it's what keeps that power and control together. So if there's no fear, then there's no control. So an abusive partner knows that they can control their victim using these different tactics. And oftentimes we see victims may not even recognize that they're in an abusive or unhealthy relationship. And so this illustration can be really helpful in working with folks just to help them get a sense of what's going on and let them know, you know, it's not okay and you deserve to be respected, you deserve to be valued, and you deserve not to live in fear. Okay.
And similar to domestic violence, when we kind of transition to look at sexual violence, it's very similar in the way that I think there's the legal definition and the legal perspective of looking at it, where we think we kind of get pigeonholed into just thinking about rape and sexual assault. Those are specific examples, those are crimes that people be charged with and go to court for, and that's typically what we think about. But our goal here and the model that we use at SARC is to think about sexual violence as this umbrella term. It's this all-encompassing, more inclusive way to think about the behaviors that cause harm that fall under this umbrella of sexual violence. So we want to think of sexual violence as any sexual behavior that happens without a person's consent. And again, it's one or multiple people doing something intentionally. It might be a pattern like in domestic violence, or it could be a one-time instance or just a couple times and not necessarily within a relationship. Because we understand that sexual and domestic violence are very often co-occurring. Within a domestic or intimate partner violence relationship, there's very often sexual violence. But you may also be working with people in the community and in the work that you're doing who have only experienced sexual violence, and that's what their experiences are. So I want to challenge us all to kind of reshape our thinking around what first comes to mind when we think of sexual violence. And the other way of thinking about sexual violence is across this continuum. So some of these other forms of harm, like sexual abuse, stalking, human trafficking, and sex trafficking, these are all also examples of sexual violence and fall across this continuum or under this umbrella. And we understand that all of these forms of violence are interconnected. Go to the next slide.
So what we know that domestic violence is prevalent in our communities. In a nationwide survey that was conducted by the Centers for Disease Control and Prevention, they found that 1 in 4 women and 1 in 7 men have experienced severe physical violence from their intimate partner at some point in their lifetime. And so that severe physical violence can include being hit, kicked, slammed against something, by strangulation or beaten or burned. So there's lots of severe physical violence. And so again, those are things that people often default to when talking about domestic violence. But if we think back to the power and control wheel, when we add in things like economic abuse or emotional abuse, we know that those numbers are likely much higher to look at what people have experienced. But we also know that number one, that domestic violence or sexual violence can happen to anyone, regardless of their sex or gender, age, socioeconomic status. We know that violence does not discriminate. But we also know that due to many issues of oppression and all of the isms that we could talk about, racism, sexism, all of them, we know that there are groups that are disproportionately affected by these types of violence. Women primarily, our default is women or female identified folks are the ones who are primarily affected. That doesn't mean that it doesn't happen to men or male identified folks or folks who are non-binary. We know that, statistics and research are showing that this is the case. However, we see women, young women, especially those before the age of 25, women of color, women who identify as bisexual or lesbian, women who are experiencing a lower socioeconomic status, so those with lower household incomes or food or shelter insecurity, or women with disabilities. These are just a small grouping of folks that are statistically seeing much higher rates of violence in our community. And so we hope that our services and our resources are really meeting folks where they are.
And what we also know is this intersection between sexual and domestic violence that we mentioned earlier is really strong. I think that's what these statistics, and I won't bore you with reading them verbatim, but what we know with the research supports is that if someone is in an intimate partner violence, domestic violence situation, there's very often that sexual violence component, whether it's like Courtney mentioned, whether it is ongoing assaults, ongoing, instances of violence throughout the relationship, or it's just that threat of violence or the fear of violence that really holds the wheel, that power and control wheel together. So we really need to think about these as two, like I mentioned, co-occurring forms of violences, and understand that when someone has experienced both sexual violence and domestic violence, that trauma is compounded. And when you add it into some of the specific vulnerable populations like Courtney mentioned, where someone might also be facing racism and sexism and discrimination based on sexual orientation, that trauma is even more severe and becomes even more compounded when we take an intersectional approach to look at these issues.
And so we know that if we look at just the impacts that violence has on folks, about 1 in 4 women and 1 in 10 men have experienced some sort of IPV, intimate partner violence, related impact during their lifetime. So that could mean that they have missed work or school, that they've had ongoing medical concerns and issues as a result of the violence that they've experienced. If it's being fearful or concerned for their safety and having to, adjust where they live or their route to work or things like that, where, for many of us, we take those things for granted, that we can go about our day and do what we need to do and not give a second thought to how somebody may be crossing our paths. But it's important to recognize that it may not seem like a big deal to have to go into another door at work or to take a different route home or go to the grocery store on a different day. But these are big issues that can affect somebody's just health and well-being throughout their life.
And with that and how they affect their health and well-being, that's really why we've made this shift in the field in both sexual and domestic violence to addressing these as a health issue, because we understand that we can kind of split this into two sort of groups in how domestic and sexual violence can affect a survivor's health. The first kind of being those physical effects, so whether it's from multiple traumatic brain injuries, from physical assaults that they've experienced by a partner, or while an assault was in progress, and the lasting complications from that. I think that's what we more so jump to, the idea of black eyes and broken bones. Even though we know it's far more than that in terms of what someone experiences, the health consequences and the long-term consequences on a person's health still stem back, and that still has very real effects for that person in the long run. Very often as well, because when they're in a domestic violence situation, or just because of the trauma and fear from the violence, they're unable to seek care. So those injuries remain untreated. They get worse. They lead to more health problems. So that's kind of the one bucket that these health consequences fall into. And then the other being those effects of trauma. So trauma and that chronic stress can really affect the body in so many ways. We all know just when we're stressed out, when we have a lot going on, if something's happened personally in our lives that we're going through something, it affects our health. And this can be everything from worsening of chronic conditions. You may see it when you're working in the community, someone who was managing something like diabetes very well for a very long time, and then all of a sudden there's this dramatic change. Or these conditions that have seeming to come up out of nowhere. I think the example that's easiest to think of is when little kids are scared of something and all of a sudden there's a tummy ache every time they have to go to the doctor, or every time they have to do something they don't want to do. That we still see that in adults. We see these effects of trauma manifesting themselves in physical conditions, whether they're almost psychosomatic, but the symptoms are still real, very present for the survivor, or it does lead to that worsening or onset of now a chronic condition. And if we can go to the next slide, like I mentioned, we need to start thinking about sexual and domestic violence as traumatic events. So we know trauma affects the body, but it also affects how your brain functions. So trauma affects really how you think, how you process decision making, how you're able to plan, how you're able to stay organized, how you're able to recall memories. So when we're working with someone who has experienced trauma, whether it be from sexual and domestic violence or another form of trauma, our goal in providing trauma-informed care is to shift our thinking from what is wrong with this person? What is wrong with them that they can't just fill out this form or they can't just remember this paperwork? And shift our thinking to what has happened to them. What has happened to you and how can I help? Because above all, we understand that trauma is a normal reaction to an abnormal event. There's no right or wrong way to respond when your body goes through a traumatic event. It's something that you're not supposed to ever experience. No one should have to go through sexual and domestic violence. So it's important that we kind of check ourselves when we're responding to someone to understanding that this person has been through something that no one should ever have to go through. So there's no right or wrong way to process this or to react.
Okay. And so when we are someone who is either working with someone in trauma or the one who is in trauma ourselves, sometimes it can really feel like we're in this state of imbalance, where it's a very delicate, fine line that we're walking, where we may not be able to make the decisions and follow through that we would normally do when we were in a better state. And so when we are, as service providers, trying to expect, just like Megan said, thinking that people can handle their medications and have those things under control, or even just know who to call if they have a problem with something in their house or something, to take care of those kinds of things, it can be really difficult. Again, they seem like such simple tasks, but trauma can really alter the way that we operate and interact, the way that we seek services, and just the way that we work with others. All right, so we want to hear from you because we now see, the kinds of dynamics of domestic violence. We know that it's prevalent in our communities. We know it's prevalent that likely we are walking next to someone who has experienced these types of things. Throughout the day, we're coming into contact with folks. And so in the chat, this is one of the biggest questions that we often hear, or the biggest misconceptions. They must be okay because they haven't left. It can't be that bad because they're still there. So in the chat, if you could just let us know, why do you think, what are some of the reasons why somebody might stay in an abusive relationship? So we'll give you a few seconds to put that in there into the chat. So we see fear. Fear is a big one. A cycle of abuse. If they leave, it could get worse. They rely on their partner. Money, finances, lack of self-confidence. Again, financial independence, manipulation, fear. Again, so all of these things, they think the person will change. Yeah, fear again. So lots of very difficult decisions that folks have to make. It's their home. They've created that home with their partner. They rely on them for housing, low self-esteem. So all of those, not having a support system, children. It's like you all are right ahead of me here. So thank you for those responses. There are a number of different reasons why folks may stay. If we could go to the next slide, we'll take a look at some of those things. And so if you've ever searched on Twitter, there's a hashtag that pops up from time to time of why I stayed, where folks are sharing the stories about why they stay, because victims are often blamed for staying in the relationship, where people say, well, I was in that situation, I pulled myself up by my bootstraps and got out of there. But what do you do when you don't have boots? So you have to take yourself out of the situation and recognize that we're all operating with different resources and different supports. And so through this hashtag, you see some of the examples there on the screen that, all of the things that you said, that there's a number of very legitimate reasons why somebody may stay over leaving. We could go to the next slide. And so it could be economic dependence. So again, if they are dependent on their partner for paying the bills, for staying at home, if their partner has prevented them from working or from keeping a job. There are so many times where I've worked with folks whose partner has done things to get them fired, calls them all the time, or takes their paychecks, or interferes with their transportation to get to work. And so that's another form of control that they can have over their partner. And so if they haven't been able to sock away some money, or even have access to any of the money that they've earned or that comes into their family, they could be relying on that person. If children are involved, that's another big one that we see, where folks will think, okay, well, at least if I stay here, my kids have a home, they have a place to live, I don't have to take them out of school, I can take care of their needs. And living in a household with both parents is probably better than with a struggling single parent, which sometimes could be the case, but sometimes not. Okay, next. The isolation, and isolation can be physical, where the family has moved away from their support system. So maybe they're living an hour away and they don't have reliable transportation or the support to get to their family or their friends or whoever it is that they're relying on. But there's also that emotional isolation that comes into play as well, where the abuser has manipulated the victim into thinking that they're the only person who cares about them or who loves them. And if somebody tries to intervene, if a friend or a family member says, hey, I think I don't really like what's going on here, I think that this isn't very healthy for you. And the abuser may just say, oh, well, they don't understand how in love we are and how great of a relationship we have here. So there is that isolation piece. The attachment to the abusive partner. So many times I have worked with folks who say, I don't want them to get in trouble. I just want them to stop hurting me. This is somebody they still love and care about, often have built a family or a household with. And so there is that attachment to them that they still care. They don't want to see anything bad happen. They just want them to stop hurting them. The shame, whether it's been going on for weeks or months or years, there are oftentimes people will think, well, who's going to listen to me? Who's going to believe me? I should have been able to take care of myself. I should have been able to take care of my family, and I should have been able to stop it. But if anybody had that much control, then we wouldn't be here. And so putting all of the blame and the guilt on the victim to be able to stop their situation, where they're not the one who started it. The abusers need to be held accountable for the things that they're doing and have done. We know that contacting the police is not necessarily the safest response for many communities. And so if folks have sought the assistance of the police in the past and it's made the situation worse, or if they have tried to go to court and it didn't work out, or they've tried to seek help and they've gotten the runaround from lots of different places, then likely they're going to give up. We don't want to be a glutton for punishment oftentimes. So instead of, reaching out to a hotline or calling 911 or doing whatever it may be that some people may say, well, that's what you need to do to stay safe. You're not going to rely on that if it's failed you in the past. We also know that abusers are manipulative and they can manipulate those systems as well. If there are any religious or societal pressures or cultural pressures to stay, especially if the partners are married, we see that folks may lose their entire support system and their entire community if they were to separate from their partner. The cycle of violence or hope for change. We've tried to get away from calling it the cycle of violence because we know that it's not necessarily cyclical, and not everybody goes through the same experiences. But we do recognize that in general, there are times where things are really good and there are times where things are not so good. And so as people, we're likely to hold on to those good times and those good memories and hope that, all right, we're in a really good space, things have been great, you know, let's hope that this lasts. And you hope that, and so there is that hope that maybe this will be the time that they change and the abuse stops. And sometimes it's predictable and sometimes it's not, but that hope can do a lot of things and keep us in places and doing things where logic may not make any sense, but holding on to that hope. And finally, the fear or danger. Oftentimes people will say, well, if I stay, I know what to expect. I have an idea of, you know, I can predict patterns. I know how to manage the situation. But if I leave, I don't know what they're capable of. We also recognize that the time where victims are preparing to leave or have recently left the situation is the most lethal. We see that the majority of intimate partner homicides that occur when the victim had recently left or was planning to leave a relationship. So it is something that there's so much unpredictability there, and so a lot of times it's safer to stay. But ultimately, we know, if you want to go next, we know that whatever the victim elects to do, that it is the safest option for them at the time. They are the experts in their own lived experience. And so chances are, if we are talking to them and coming up with ideas about safety planning and what to do, they may have been through all of those things and back again. So it's really important that we listen and we trust the expertise of the folks that we're working with. To ensure their safety. So whatever their decision is, you know, we're looking at it on the outside. Again, what may seem logical does not make any sense in their situation. So we really need to honor them and their experience. And again, financial abuse is something that I mentioned earlier, and that was something that came up several times in the chat. But we know that financial concerns can really keep people in those relationships. Money talks. And when you don't have money and you don't have access, then you're really stuck. And so when we have partners who are controlling that access to money, again, preventing somebody from working, controlling bank accounts or destroying credit, you know, it's estimated that 99% of abusive relationships involve some sort of financial abuse. And so again, that's another big factor to take into consideration when we're working with folks. So many of you are here because you likely want to help, whether it's personally or professionally. You have a vested interest in helping others. It's one of those things that those of us who are in, you know, victim services or healthcare or social services or whatever it may be, we want to do whatever we can to help. And so just before we go ahead, I want you in the chat once again, I want you to give me one word that would describe how you would feel if someone were to disclose that they were a victim of domestic violence or sexual violence to you. How would that make you feel to receive that disclosure? Just one word, and you can put that in the chat. Angry, hurt, sad, empathetic, concerned, vengeful, upset and concerned. Yes, all very valid emotions. Very sad, afraid. Yes, lots of these things come up. You know, when we're working with folks, that nervous is another good one. Trusted and empathetic. I really like that. Compassionate. All great words. You know, it's, you know, as a human, as a person, I think our initial reaction is to be, and depending on the relationship with that person, that we feel, you know, we want to protect our people. So we want to do whatever we can, whether it is, you know, your first instinct may be, I want to jump up and I'm going to take care of it myself, which we don't encourage people to do. But we also want people to, you know, channel that and remember that, you know, you have a lot of power and a lot of, it's a privilege for someone to disclose to you. And so those of you who are saying trusted and compassionate and supportive, I think we're all probably feeling that way, but that may not be the initial feeling that we get. But as much as it is hard to hear, it is hard to hear those disclosures, especially if it's somebody from somebody that's close to you. But recognizing it as a gift that this person trusts that you are going to listen and believe and support them. And beyond anything else, that is something that is so important. We could go on to the next slide. And so just some of the things that survivors tell us. You know, some people get very nervous about getting a disclosure and they say, well, what if I say the wrong thing? Or what if I don't know where to tell them to call, or I don't know what the resources are. And that's okay, because people want empathy. They want people who are listening and who will believe them. They want people who are going to give them hope that they can come out on the other side stronger than ever. And I want people who will listen and accept and honor their stories, and demonstrate humility. If you don't know, if you don't have all the answers, it's okay. Sometimes it's just helpful to be that person who is sitting and listening, and just being present with them can be such a huge thing for them. But really supporting and empowering them, and recognizing that, look at all this strength and look at all this courage and resourcefulness that you've exhibited. And you've got this, and I'm here for you, and I'm going to be here with you every step of the way.
Unmute first. So for the rest of the time, we're really going to focus on just what Courtney said, of when in this moment, if someone shares with you that they have experienced sexual or domestic violence, what can you say? What can you do? I know I didn't come from a direct service background. I kind of did the flip-flop with Courtney. I started in prevention and then moved into direct service. And it is scary the first time you're working one-on-one with a survivor, particularly for you all if you're not sexual and domestic violence advocates and you're going into maybe the healthcare field where this is not your background. It's scary in that moment of, I don't want to say the wrong thing. I don't want to do the wrong thing. Best advice, particularly when I'm training our advocates, for example, who work on our helpline, the best thing you can do is shut up and listen. I know it's hard. It's in our nature as humans that we don't like to sit in silence, but a lot of this is just being comfortable in silence. It's being comfortable in allowing the person you're working with to have the space to share what they want to share, and to take as much time as they need to share whatever they're ready to share in that moment. And it might not be the full details of what happened. You might just get a little bit, and that's okay. And when they are done sharing, this is just a brief script, not even a script, some key phrases that can be that supportive, minimal encourager, like Courtney mentioned, to help someone out. So just responding with something like, I am so sorry that happened to you, but I'm so proud of you for sharing this with me. Thank you so much for trusting me with this. I know how hard it was for you to work up the courage to share that. And I believe you. I believe this happened to you. So really our response, and that key trauma-informed response, boils down to those three things: just to listen, believe, and support them. And always remember that it's never the goal for someone to disclose. You are going to see so many people throughout your life, in your professional capacity and in your personal life, that have experienced sexual and domestic violence, and most of them will never disclose what has happened to them. That is okay. People will share their experiences when they need help, but also when they feel ready to and comfortable to. So if we can go to the next slide. Just a couple other reminders of things to keep in mind when you're working with someone who has disclosed. You always want to keep their privacy and confidentiality number one. If it's not a situation where you have to tell a supervisor, or if it's a mandated report by law, which most of the case it's probably not going to be, you want to respect that confidentiality. And if you don't have to tell someone, don't tell them. You also always want to let them lead. Let them lead the conversation. Let them lead what happens next. Let them choose what resources they want to take advantage of. And you want to offer some of these resources we're going to talk about with their permission. So they might say, it's not safe for me to call a helpline, or it is not safe for me to go to the hospital. That's okay, because they're the experts on their safety and what they need. And if we can go to the next slide, a couple other things that are just best practices when working with a survivor is to never assume that the person knows what's available. One of the first things I do at the start of most trainings after I say I'm from the YWCA Sexual Assault Response Center, show of hands if you've heard of us. Maybe a couple of hands in the room, and that's okay, because we never want to assume that people know what agencies and what resources are out there. And a great thing you can do is when you're making this referral and connecting them to a resource is offering, if you have an office phone, or if you have, I know for us in direct service, we have like an on-call phone as well as our personal phone, because you never know if their phone or technology is safe. And you always want to connect them to a community resources in that moment, because this moment right here where they just closed might be the only 10, 15 minutes, 1 hour that they are guaranteed safety. So you want to maximize that time as best you can. You want to get as much done in this little window of safety, because you want to assume when they walk out that door, it might never be safe for them to connect with a resource again. So we can jump to the next slide. These are just a couple examples, excuse me, a couple examples of what community resources we do have. We have 24/7 hotlines, shelters, case managers, protection from abuse orders, which are one form of that legal supports in place. And these are all operated and run through a couple agencies that I just want to highlight, because I want you to be familiar with them. Keep them in your back pocket as we go through them. I would highly encourage you to write these numbers down, because a great thing to do is create contacts in your phone with the agency number and their 24/7 number. So if you ever need it, you have it right in that moment when you're working with the client. So if we can jump a slide, our first resource I want to talk about is an agency called Child Inc. They are our domestic violence shelter agency up in Newcastle County, downstate for me working with People's Place. But upstate at Child Inc., it's not just for children. They run our 24/7 domestic violence hotline, but they also run this program, which is Community Health Advocates. They are a wonderful, wonderful resource. They are mobile. 2 of them are bilingual. They are in the community. They are meeting survivors wherever is safe for them. And their goal is not only helping that survivor achieve safety and stability, but also helping out with their health goals and their health needs. So that might be helping them navigate insurance and billing and setting up appointments to get them connected to care, and then transporting them or helping transportation to those appointments. And it's also some of the more traditional domestic violence safety planning, things that we would think about, like connecting them with case management, getting them connected with a counselor, helping to increase some of those safety measures that they can take in their lives. And if we can jump to the next slide, just want to talk a little bit about where I'm from with the Sexual Assault Response Center. I said I'd go into depth a little bit at the beginning, but we are a 24/7 sexual assault and domestic violence really resource center. We have 3 offices across the state of Delaware, so all of our services are statewide. They're all 24/7. Our biggest thing is that helpline that people can call anytime, whatever they've experienced, get connected with an advocate. We also meet survivors at the hospital if they need to go through a SANE or sexual assault nurse examiner examination, or if you've heard of a forensic kit, or commonly known as a rape kit, we'll go with them and meet them at the hospital. We can also accompany them if they would like to report the assault to police. We never require them to report. We never pressure someone to, because we understand it is their experience and they're the expert on it. But if they choose to report or go through the criminal justice system, we can always accompany them to the police station, to the courthouse, maybe to get a PFA like I mentioned. And then in our offices, we offer counseling, case management, and support groups. All of our services are 100% free. We don't ask for insurance. We don't ask for donations or anything. We're totally free. Everything is confidential, and everything is open to any primary or secondary survivor 12 and older. And when I say primary and secondary, really what that means is take sexual assault, for example. Common example is when I go to the hospital on an accompaniment, I meet maybe a high school student who was assaulted. So she would be, or he would be, the primary survivor. And then they're there with their parents. And the parents would be secondary survivors, because we know that sexual violence and domestic violence doesn't just impact the victim survivor, it really impacts everyone in their support network. So we offer those services to everyone in that support network. Right now, we are currently closed just because of COVID. We're open by appointment only, and we're doing everything virtually. So our accompaniments, we can't go safely in person right now. So right now, everything is over the phone. And if we can jump one more slide. Like Courtney mentioned at the very beginning, there is also kind of this strong overlap and connection between sexual and domestic violence and the legal system. So we have survivors experience everything from food insecurity to needing income supports like public benefits. Right now, housing is a really big issue with people who have been laid off or unable to work during COVID and then are facing homelessness. So the legal needs of survivors that also address some of these social determinants of health is why we've created this medical legal partnership with the Community Legal Aid Society. And Child Inc. and the Community Health Advocates participate in this program as well. So if you have someone you're working with and they're talking about that they can't get access to like food stamps, they're having trouble with their disability, they're worried about their immigration papers, they need a protection order, anything in this legal umbrella, we're connected with these attorneys at Classy, Community Legal Aid, who can provide, again, free legal assistance for our clients. And if we can jump one more slide. These are some of those numbers that I would highly encourage you to put in your phone if you're going to be working in the community. These are 24/7 domestic violence hotlines. Again, if you can create a contact or if you have an iPhone, put it in a note, just all of the helplines, put our SARC 24/7 helpline, put that community health advocate number. Again, they are wonderful. And if we can go to the next slide, you'll get a copy of this, don't worry, if you didn't get a chance to write it down. But there's also some great national hotlines and resources. Sometimes people like to call an agency that is not in Delaware. If you are a native Delawarean, or like me, you have chosen to become a Delawarean, you will learn very quickly that Delaware is small and everybody knows everybody. So some people prefer to call a national helpline where they know it's going to be anonymous, where they know there's not a chance they know someone picking up the phone or that works at that agency. So I know we're coming right up on the end of time. If we can jump to that last slide. I just want to say thank you again. I know we went really quickly there at the end about some of the how to directly work with survivors. So if this is something you are interested in, passionate about, or you have more questions, this is Courtney and I information. Please take a picture of this, write it down. We are always happy to help talk about these concepts in more detail. Or if you have a particular scenario or situation that you want to bring up, we can also always talk one-on-one offline about this.
And I'd just like to echo everything that Megan just said. Yeah, please feel free to reach out. As I mentioned, at the coalition, we don't directly do, or we don't do direct service, but we can certainly help connect you to folks who do. But we can also assist you if you're looking for resources or training. Feel free to reach out as well.
And I know we mentioned a lot of different hotlines and a lot of different agencies, and it can be very overwhelming of like, which one do I call? call any of us. We can get you connected.
Yes.
We share most of our clients as well, like we mentioned, because of that intersection between sexual and domestic violence. I was just calling community health advocates, calling Maite last week saying, hey, we've got this client, she's your client too. We were working out, trying to get her connected with something else. So call any one of us and I don't want that to be the barrier
Yes.
for anyone.
And I know Megan talked a lot about Child Inc. and the Community Health Advocate Program. We are working on hopefully expanding that program downstate. But the services that Megan talked about, the hotline and shelters and advocacy, those are all available through People's Place as well. So they're available in Kent and Sussex and provide very similar services to what Child Inc. does upstate as well. So thank you so much for joining us today. I'm going to turn things back over to Christine to see if there's any questions.
Great. Thank you so much, Courtney and Megan, for your topic about something that is very important to all of us. And it was very informative as well. So at this time, if anyone has any questions please go ahead and put those in the chat box, and Courtney and Megan will answer those for us. So we'll go ahead and give everyone a moment or two to submit those.
And we can always go back and go over anything else. I know we were rushing pretty quickly at the end. So if we didn't quite go into something in depth, we can always go back and revisit.
And while folks are doing that, I can just say about resources as well. The link to the coalition's website is up on the screen. That's dcadv.org. And we have a list of all of the different statewide resources that are available. But we also have a special page that's dedicated to resources related to COVID-19. There's been a lot of concern about, are DV services or sexual violence services still available? And so we have a number of resources and supports that are there on, you can get to that from our homepage. So if you get to our website, you can find pretty much any of the information that we've talked about today.
Great, thank you. We did have a question come up. Does legal aid attorneys provide divorce proceedings for victims?
So it depends, but not typically. Usually it's just that protection from abuse order. And there's two agencies, at least in Newcastle County, that work in that, and that's Domestic Violence Legal Services, DVLS, and then Class C Community Legal Aid Society.
Thank you. Someone had asked a question if they could get an email of these resources, just so everyone knows that at the end of this presentation, once we've had an opportunity to go ahead and edit it, we will be sending out the PDF of the PowerPoint, so you will receive the PowerPoint along with the resources. And there was a question that came in that says, have you heard of the situation where divorced moms can't get child support because they are forced to live with the ex-partner due to having no money?
Courtney, do you want to take this or you want me?
I mean, you can start. I think we're probably going to say the same thing, so I'm going to let you go first.
Yes, that is definitely not uncommon. Like Courtney mentioned, financial abuse and really this financial inequity is one of the most common reasons for not leaving. And also, unfortunately, not paying child support can be both a tactic for the abusers to force the survivor to keep going back into court and to keep having to repeat their story and see the abuser in court and face them. It is totally not uncommon. That's also one of the main reasons that we have our partnership with Community Legal Aid to help out in those situations and to give the survivor representation in court, because very often it's the abuser who would be paying child support that is able to pay for an attorney, so they end up faring better in the court system, and survivors are unable to pay for their own representation. So yes, unfortunately, it is not unheard of, if not common.
Yes.
Thank you. Another question, who can make referrals to domestic violence community health workers at Child Incorporated? Can churches, schools, family members?
Yeah, anybody can make a referral to the program. So they are when they have specific hours, they're available 8 to 8 Monday through Friday, and if it's time where they are off at that point, the calls will roll over to the domestic violence hotline. So they're still available 24 hours a day. It may just be, you may not be getting directly the community health advocate, but anybody can make a referral to those services. Like Megan said, that they are mobile, they can go wherever, they can help wherever they can. They do have a lot of resources at their disposal to help with anything related to domestic violence or somebody's medical needs and making those connections.
A follow-up came up to that was, do you need proof that the person is a victim? For example, do you need a police report, protection from abuse order, etc.?
Nope, it is all self-determination. So if somebody is contacting the community health advocates and identifying as a victim of domestic violence, that is enough proof for them. So it is all self-determination.
New question.
And same goes for the,
Go ahead, Megan.
sorry, my connection is a little slow, so I think I'm chiming in late. I was going to say that's the same goes for our medical legal partnership for both Child Inc. and us at SARC with Classy. You don't need to have any kind of legal paperwork to be eligible for it. It's just a self-identified survivor.
Thank you. New question. How would shared custody with your abuser work?
Depends on your PFA.
Yeah, so that's something that's going to be very individual to each, to each situation. So, so that's not something, we're not attorneys, so we can't give legal advice, but that's definitely something that Classy could assist with as well as through the PFA process and things like that.
Good, thank you.
Some of the options are virtual visitation, and we have Child Inc. operates those People's Place visitation centers for supervised visitation. So they have information on how visitation works as well. If that's, again, like Courtney mentioned, part of that PFA agreement. Thank you, Courtney.
I have another question. What if, especially due to COVID, victims struggle to leave their house? And if it's not safe to call or go on computer while abusive partner is home?
And that is an unfortunate reality. Megan, do you want to talk any about the engagement that you've all had with folks through SARC in that respect?
Yeah, I mean, it's definitely something that has come up, and actually it's one where we've relied a lot on healthcare workers. We've gotten more referrals of people coming in for treatment, and then thankfully we have providers that are doing domestic and sexual violence screenings, but we've gotten very crafty. I know community health workers have as well, in terms of meeting people in grocery stores, and survivors are very smart at knowing their abusers' routines and those windows for safety. So sometimes we can only make a call when they call us, we can't call back. We have that in our system. We have a code word. We only have 5 minutes of guaranteed safety right after the car is pulled away. But it is challenging. We make it work as best we can. We've gotten pretty good at knowing safety protocols and creating code words, and we never call back without that person's permission, and we're very careful. We don't ever call someone and say, hi, we're the Sexual Assault Response Center, because we don't know who's answering that phone. But yeah, it's hard, and it's been a really difficult system to navigate.
Next question, can you text 911 in Delaware?
Yes, we have tested that.
Of the resources or advocates, can you text for help that I'm imagining that question is probably related to the resources that you have within the PowerPoint. Are some of those numbers that we can text, or are they all phone calls?
I know the national hotline has text and chat capabilities. I know the domestic violence hotlines do not have that currently. Do you all have text chat through SARC?
We don't. Once we're connected with a client, we can communicate via email, or our case managers can do it via their secure work phone and chat, but not our hotline. But all of the, like you said, national hotlines that we gave out in this one, you can text them.
Mhm.
We're getting there.
One day. And one thing
Well,
to note about the national hotlines as well is that if you'd like, they can connect you with your local hotline. So if you're, oftentimes folks will call the national hotline because they're not sure who the services are in their area or where they should go. And so they're a great resource for someone who, if you're trying to help somebody who's in another state, they can help you directly connect to the people and the services that are closest to you.
And I know the National Human Trafficking Hotline through Polaris just bounces right to our SARC helpline for Delaware. So we also get all those calls.
Oh, thank you, Samantha.
Yeah.
People's Place does not have a chat hotline as well. So we're working on it. It's definitely something as we've tried to look at services, especially through, in the times of COVID, and just we're looking at, confidentiality issues and security issues. And so there's a lot to take into account. And so really, we just want to be mindful of safety for everyone who's trying to contact.
And it's very difficult staffing wise with advocates too, since most people when you're answering a hotline are volunteers. They're donating their time. They don't get paid for that. They go through days and days of training, if not weeks of training, really.
Yeah.
So it's a lot for them.
Mm-hmm.
great. Thank you, Megan and Courtney, so much for answering all those questions. And I think right now we have a poll that we would like to have our audience participate in. And we will get that going here in just a moment. We'll give it just a little bit longer here so everyone can have the opportunity to respond. We have a 72 response rate, so we just give people another moment here so we can get others to respond. We really appreciate your feedback. Okay, looks like we have an 86% response rate, so thank you all of you who were able to respond to this poll here. Okay. So I believe this concludes our presentation at this time. Again, we want to thank Courtney and Megan for being with us today to share information on domestic violence, recognizing and referrals. Again, I'm Christine Sawinski. I am the, project coordinator for the Mobile Health Program. If you have any questions at all regarding the Mobile Health Program or about our webinar series, please do not hesitate to reach out to me. My email is listed here on this slide, as well as if you have any questions about the Partnership for Healthy Communities, please reach out to Noelle Duckworth. Her information is also on this slide. And we do hope very much that you will be able to join us next week for our 6th and final webinar series for the summer. It is on nutrition and aging. And again, that'll be next Wednesday at 2 p.m. Tomorrow, we will be sending out an eval. We would appreciate if you could complete it in reference to today's webinar, as well as tomorrow we will be sending out the invite for next week's webinar. We hope that you will be able to join, and please do pass it along to friends, family, community members so that they can also participate in our webinar series. So thank you, and everyone have a great day.